Um, right. Thank you very much, madam, for having me here today. And it's a pleasure to meet you and meet your group. About Parkinson's disease, I think when Parkinson's disease was initially identified and a lot of work was being done on that, there was a lot of, and as we discover any new condition and any new illness and we try to understand that particular condition, we are seeing that with COVID right now with coronavirus, and we are understanding more about it, we will know a lot more problems that come with it. Similarly, when the medical fraternity and the brain research fraternity, when they started looking at Parkinson's disease initially, everyone thought it was primarily a disorder of the motor system. When I say motor system, it's about to do with movements, and we know there are particular organs or particular areas in the brain which are primarily responsible for controlling, coordinating our movements. And those areas were thought to be primarily affected in Parkinson's disease, and that resulted in people having problems with their movements. So they were kind of a bit slow when people moved, or they may have lots of tremors, they may be a bit rigid, and then subsequently people fell down a lot. So those are some of the main problems or issues that were identified with Parkinson's disease. And for a long period of time, it was primarily considered as a motor disorder. But subsequently, and when we kind of knew more about it, and when we started following up a lot of people who are affected by Parkinson's disease, we realized that Parkinson's disease not only affects their motor system, but it also affects a lot of other brain functions, primarily their emotions, perceive things, their perceptions, and also talking about cognition, their brain ability to understand, to process information, and then to make sense of what is going on around them. So that's what cognition helps us to do with. So we understood that Parkinson's disease can have a myriad of effects across all these brain functions, and we realized that it's not just motor system problems. So when you look at treatments for Parkinson's disease, initially when the treatments were initiated and we started talking about dopaminergic drugs and drugs like Syndopa, Levodopa, which has been used quite extensively, and more recently a lot of drugs have been discovered and are being used in Parkinson's disease. We realized that these drugs, while they improve the motor symptoms, had a lot of or very little effect or no effect to very little effect to adverse effects on their other kind of components of brain functions. So that's something which we started seeing a lot. And in fact, we identified that people with Parkinson's disease can have a lot of emotional dysregulations. They can have plenty of anxiety symptoms, plenty of depression symptoms. There are lots of studies to show that almost 40 to 50% of people, or even 60% of people, according to some studies, and depending on where it is done, have had experiences of depression, anxiety, and fear. And particularly, one of the important fears that people with Parkinson's disease have is fear of falling. So that kind of becomes an overwhelming problem for many people with Parkinson's disease. So this emotion dysregulation and emotional disorders mood disorders came about to be an important association in Parkinson's disease. And the other important area where people started seeing more complaints or more problems were with people having abnormal perception. So it can be seeing things which are not there, or hearing voices or hearing sounds when others can't hear them, or having some false beliefs which are quite sometimes can be very bizarre, but sometimes can be very realistic, but still nonetheless false. They would experiencing that people were going to do harm to them, or they may start saying things that their spouses were having affairs, or they were children doing something behind their backs. So they started having all these kinds of unusual new false beliefs which they never would have had otherwise if they didn't have Parkinson's disease. So these kind of symptoms started to come about a lot, and then we realized that there was a lot of association between these symptoms and starting them on dopaminergic drugs. And we saw that when people were started on dopaminergic drugs, these unusual symptoms more than what we would see if we didn't start them on these drugs. And also found that so what happened was that there are areas in the brain which are primarily for thoughts and for perception. And when these areas are also kind of mediated, the functions are mediated by dopamine. Dopamine is an important neurotransmitter, and that particular neurotransmitter is deficient in the areas in the brain which control motor behavior. And when motor symptoms are affected, it's natural that if we find a drug which can improve dopaminergic activity in those areas of the brain, that would actually help their motor movements. And that's what we initially found as beneficial with when we start somebody on levodopa, syndopa, you will see that their tremors become a bit better. They are a bit fast when they walk, and they are less rigid in their movements. But unfortunately, while dopamine has a beneficial effect on these regions, a higher dopamine, higher than usual level of dopamine in other regions of the brain can cause this unusual, abnormal side effects or symptoms, such as seeing things which are not there, hearing things which others can't hear, and or starting having these false beliefs, which we call as delusions. So these things started to happen more in these people. Now, there are various reasons why these symptoms collectively are called as psychotic symptoms. So hearing things which others can't hear, or seeing things which others can't see, or which is not actually there, or even sometimes misperceiving things. So they may see a screen, fluttering in the wind, and they may think that there's something going on there, or they may see some patterns, and they may assume that there is a person or an animal or something is going on there. Now, that kind of misperception of stimuli or new perception when there is nothing, which we call as an hallucination, or they may have these false beliefs, which we call as delusion. So these things collectively are called as psychotic symptoms. And these psychotic symptoms can happen in people with Parkinson's disease because we are starting them on a drug which increases the dopamine activity in the brain. And sometimes it can also happen even otherwise with the disease progression in Parkinson's disease. We see that even without any dopaminergic drugs, or even without increasing the dose of dopaminergic drugs, we'll see that these symptoms happening a bit more. And again, in a few people, these psychotic symptoms can happen without any actual, we can't really explain why that happens. And that also happens in a very small proportion of people with Parkinson's disease. So these are some of the kind of symptoms that we see in Parkinson's disease. Now, when this happens, it can be very distressing for the person experiencing, very distressing, because when they start becoming who's kind of spending a lot of time giving up everything else, and this person to be ungrateful and accusing them of things, and that can be very difficult to take for the caregiver. Even otherwise, it's very difficult to see your loved one being very problematic, very troublesome, and very disturbed, and that can have a huge impact on the caregiver. So that again needs to be looked at very carefully. It kind of has an adverse effect on the person's quality of life, on their general well-being. When they become more anxious, more agitated, they are at risk of doing things that can be harmful to them. They may be physically assaultive, and that can become a problem. They may fall down because they're very agitated and restless, and they become, when they become very agitated, they can actually fall down during that process. So when these things happen, we have to try and address these symptoms, because they are very distressing and they decrease the quality of life quite considerably. And there are lots of long-term studies which have shown that when someone has these psychotic symptoms, as we call them, it can have a very negative impact in the overall outcomes for Parkinson's disease as well. And they kind of have decreased, their survival time decreases, and it may also result in a lot of problems going forward. So they can develop a lot of depressive symptoms. They may become more anxious, and they may also have increased risk of developing cognitive impairment, what we call as dementia. So these things can kind of happen. Now, what is important to understand in all of this is that we need to look at Parkinson's disease as a overall brain disorder, and it's not happening in one particular site which just controls movements. So when we have that understanding, and when we approach a person with these complex set of symptoms very systematically, and we try to understand where the problems are and how we are going to address these problems, that helps us to help the person better, and also having a very realistic expectation of what can be achieved. See, one strategy when we are trying to deal with someone with a lot of psychotic symptoms in Parkinson's disease is we advise decreasing the dose of their dopaminergic drugs. Now, yes, it will reduce their psychotic symptoms to an extent. It may completely resolve the psychotic symptoms completely. But unfortunately, it may make them a bit slow. It may make them, have more tremors, or it may, result in them being very unsteady in their gait and all of that. So it's sometimes trying to get a balance of these two issues. So when we try to improve the motor symptoms, the psychotic symptoms become worse. And we try to address the psychotic symptoms, their motor symptoms get worse. So it's kind of sometimes becomes a very difficult balance, because when we try to address the psychotic symptoms, giving them drugs for psychotic symptoms, by definition, psychotic symptoms are understood to happen when there is an increase in the level of dopamine in the brain. So when we give drugs which decrease the level of dopamine, naturally the motor symptoms of Parkinson's disease will get worse. So it's like, it's a seesaw. So you have to really balance these two things, and it takes a lot of effort. It takes a lot of time to get the right balance, because there is no prescribed dose for that's universal. Each person has a different threshold. Each person has a different need, and we also need to look at their social circumstances and things like that, which will help us to get the right balance for them. So it can be sometimes a bit a time-consuming process, can be a bit frustrating, and this happens a lot when I see people with Parkinson's disease and psychosis, and people have sometimes I would call it an unrealistic expectation that if I give them a drug for a day, for a week, then they will be completely fine and they will get back to how they were before. Unfortunately, it doesn't work like that. In a few, if you're lucky, yes, with one drug, in a week to 10 days, things will change dramatically. But unfortunately, the majority, it takes a while. It takes a few months sometimes for us to get the right balance work out for the person. And that is a very crucial period for the person to understand that, for the family to understand it, and also for the physician to hold that uncertainty, to hold that anxiety. And that sometimes I find it the most difficult phase when you're dealing with someone with Parkinson's disease and psychosis, is delivering this message in a very non-threatening way to the family, in a way that they can understand, in a way that doesn't cause them to become frustrated. Because as I said before, this is a very frustrating experience for everyone, not just for the family members. See, as a physician, when a person comes to me and I give them a treatment, I offer them a treatment plan, I expect it to work. I too want the person to get better as soon as possible. But unfortunately, it takes a while, and while it's probably relatively easy for a physician to distance themselves and say, okay, it's going to take time. We are going to go through the process. There is a protocol which we need to follow, and I'm kind of going through the protocol. And the first step, it works, fantastic. If it doesn't work, we'll go to the second step. And if it works, great. If it doesn't, then we'll go to the third. So there's a protocol which we tend to follow. It is frustrating when we go down the protocol and we're going third, fourth, fifth step, and we find that things aren't getting any better. It can be a bit frustrating as a physician, but I can imagine how difficult it must be for the family as well during that time, so because they are experiencing all these problems all along. But one thing which I would like to say is, during these times, it is difficult. I understand. I think that's where a support group like what you're having right now will be most useful. And again, an important issue here to understand is that some of these symptoms are not manageable just with medicines alone. and you need to have a lot of social support. You need to have a lot of psychological interventions, behavioral interventions, which need to go in. I'll give you another example. When you have someone, I mean, these are live patients that I've seen before. I'm sure many of you would have had these experiences at home as well. I gave you an instance wherein when someone sees a screen fluttering, they may have a curtain, a pattern on the curtain or on the floor. Many old style homes have a mosaic floor or a tile floor with a lot of patterns on the floor. Now, these things are quite problematic when you have someone with Parkinson's disease, when they see those patterns and they start, experiencing these things like something is crawling on the floor, or they may see insects on the floor, they may see snakes on the floor. These are common, experiences in our culture where people see snakes, crawling on the floor. Can be very threatening. Imagine you're sitting in a room and suddenly see a bunch of snakes on the ground. It can be very threatening for you. So when you understand that, the best strategy here would be to actually change it. Remove the curtain, have a curtain with no patterns on it if you need to have a curtain, or if you have a floor, you can try and change it. You can probably have, having a mat, kind of having a quite problematic because it increases the risk of falling. What I would recommend is have a floor covering like a lino cover, which is relatively plain and which the person is very used to. And I have used in many circumstances, I've recommended and has been quite useful, is to have a red, used to the red flooring, cement, and that's something are quite, we are as a culture, we are quite familiar with that. When I floor, so I remember that, and many of us may have fond memories of living in a house with red flooring. So you may want to kind of have a red lino, which is relatively easy to acquire, easy to maintain, and there are non-slip variants available. So those kind of practical, simple things, in addition to giving medicines, can have a huge impact. And another important factor to remember is how people react around them. When someone is saying that there is an animal there, or there is somebody standing behind the curtain, you can remove the curtain, you can tie it up, and then they can see for themselves there is nobody there, and that might reassure them. But sometimes if they persist that there is somebody there, there's something going to happen to them, instead of having an argument with that person, saying that there's nothing there, you don't have to worry, I'm not going to do any harm to you, it may be more useful to have a conversation about how it's affecting them. It may be something, well, it's a very scary experience. Sometimes, an empathetic comment or empathetic approach to the problem can have a huge impact on how the person understands and how the person can, to relate. So if when I am very disturbed, and when someone comes and tells me, why are you so disturbed? And then I tell them I'm disturbed because of this. And then they say, well, you don't have disturbed because of this. This is nonsense. There's nothing going on there. I have an experience which is very true to me. And when someone comes and tells me that your experience is nonsensical and doesn't make, you don't have to think about it because it's not worth it, then it actually makes me feel miserable, makes me feel put down. And I may choose to ignore you completely, or I may choose to argue with you. And then that's when I say, illa, it's happening, I see it, and it's definitely seeing that you cannot see it, and you're not seeing it, or you say you're not seeing it because you're becoming part of it. So I may start making those kind of assumptions, and you're not with me, but you're against me. So that's a kind of, the understanding that I might develop as I kind of go through this process. So instead, if I am being told by someone, by my caregiver, it may be my wife, my children, they may come and tell me, yes, I understand, it must be very difficult for you, and if I am in your position, I would probably feel the same way, but let's think about it. I know it's very upsetting for you. I'll try and help you in this process. See, I've removed the curtain. I can reassure you there's nothing there. But why don't we change? Why don't we move away from here? Why don't we do this instead of just sitting here and doing it? And often when you have someone with psychotic symptoms in Parkinson's disease, when you look at their day-to-day routine, you will see that they are not being occupied. They are not being meaningfully occupied through the day. And that's when you will see a lot of people experiencing the psychotic symptoms. Usually you will see the psychotic symptoms in the late afternoons, the evenings, when the person is sitting in their room doing nothing, when there is very little light in the room. You have the natural light is falling. They have a very dim source of artificial light in the room, and there's lots of clutter and lots of shadows falling in the room. All these things are a recipe for problems occurring for a person with Parkinson's disease. So in that scenario, I would say change the environment, make it clutter free, have a bright light in the room, remove things with patterns, remove things with too much color or too much stimuli going on here and there. Remove all that, keep it very plain, keep it very simple, have a lot of light, and keep them engaged. So when you see that someone is becoming or experiencing a lot of the psychotic symptoms later in the day, towards late afternoons, usually you will see that someone has a midday nap or an afternoon nap, and then they wake up from that, and that's when they become a little bit confused and they may start seeing things which are not there. So the best approach to this will be, if we can avoid the afternoon nap, that will be really good. But for many of us, it will be a difficult because it's been a lifelong habit. So maybe expect that things are going to be difficult when they wake up from sleep. So don't give them too much of stimulus at that time. Let them wake up in a brighter room with lots of light. If possible, have the doors open, ask light to come in, and with very little shadows, position their bed or position their chair in such a way that they see natural light, and there is no shadow. There's no shadow falling on things. If I'm sitting, I'll see my shadow falling in front of me, and maybe something in front of me, and it is not casting a shadow on things around me, and there is not much of clutter in the room, so that there's nothing to confuse me to have more shadows in the room and things like that. So there are not many things that I can misperceive in that particular setting. And also I have someone who is keeping me engaged and keeping me occupied in something that I enjoy. And another thing is, when I ask the family member, when I ask someone to keep them engaged, what usually happens is I find that they are given a coloring book, they are given a color pencil, and start using it on a regular basis. Now, I kind of look back in my own life, coloring pencil to keep myself, and that's the last time I ever used a coloring book or a coloring pencil to color anything. I mean, it's not my thing. I don't like to color. I don't like to, do art-based things. For me, I may kind of be better off, enjoying music, reading something, talking to someone. Those are the things, or I may enjoy more going out, being out in my garden, doing things. And interests are, we need to design activities that are meaningful to them. So that again is something which we need to kind of do more. So I encourage the family members to discuss. And sometimes we don't know, our interesting is kind of, but as I mature, as I get older, my interests change. So I may be listening to rap music at one stage, but now I'm more into classical music, and so that kind of our interests change. So you may have to look at what they liked in the past, but also think about what they would like at this point in time, what would be meaningful to them, and then encourage them to participate in that. And again, another important aspect here is, what is it they can manage? What is it that they can manage without feeling stressed? As I said, people with Parkinson's disease may also develop cognitive impairments. They may not have on and things like that. So we need to actually design. So it's a challenge. I'm not saying it's very easy, but it's doable and it needs to be done, because if you're not doing it, you're actually increasing the risk of them being idle, not engaged in things, and that results in increase in psychotic symptoms. So a lot of cognitive stimulus, cognitive, keeping them active, keeping them socially, and another important thing is social engagement. Get them, get get them, being active socially. Get them to, don't isolate them, and if they prefer to speak to people, get them, people to come and talk to them. And I know with the COVID and all that, currently it's very difficult, but we have the option of meeting people electronically, virtually. Those things can be encouraged. And I think what you're doing right now with the support groups is fantastic. Actually, I wish you could do this more often. And that's something which I recommend. If you're able to, and if you have access to technology, I would say increase the amount of social interaction that you can have with others. And that actually has a huge positive impact on overall mental health, reducing the risk of psychosis, reducing the risk of developing cognitive impairment and dementia later on in life. The other common associated problems when someone has, these illusions or hallucinations is when they have vision or hearing impairment. Again, Parkinson's disease doesn't happen alone by itself. When someone has Parkinson's disease, they may also have cataract. They may also have vision problems with their, they may have retinal changes, which are quite common as we get older. And hearing also, many of us, as we get older, our hearing comes down, and and that also leads to a lot of misconceptions. I see my wife and and I may immediately assume they're doing something. They're talking about me, and they may be, thinking about something to do with me. And the common fear that many have is that, am I a burden to this family to handle, and will they put me in a nursing home? And that's something which many people who have Parkinson's disease, or even otherwise who have lots of disabilities, may think that way. And that results in a lot of anxiety. And again, this is something which I commonly see. A simple strategy here would be to check their hearing. If they haven't had their hearing checked, get it checked. And if they use a hearing aid, encourage them to use hearing aid more. If they are using a hearing aid, check if it's correctly calibrated, and also check if the batteries are working. Those are common practical issues that we sometimes see. So overall, when you approach someone with psychotic symptoms with Parkinson's disease, it's important to understand that it's because of chemical changes happening in the brain. It's not something they're doing it wantedly, to create problems for the caregivers, or it's not something that they are generating themselves, or imagining just like that. It happens because of changes happening within the brain. That's the first point to remember and understand. The second point is that the balance that we need to strike when we kind of looking at the medicines, the drugs that we're using for Parkinson's disease, motor symptoms control, Parkinson's disease, psychotic symptoms control. It can be a difficult balance to arrive at, but can be arrived at. It may take a while for some, and it may take a shorter period for others. But we can get there overall. The third, medicines, other factors into operation, how we how react around them, not to confront them, not to argue with them, but have an empathetic approach to handle this problem. Look at the environment, look at the setting. That becomes very important when you're dealing with it, and also keep them occupied and engaged in a meaningful fashion. And that again is important. If you do all these things together, so medicines alone will not work, and you will find that as we increase the dose of medicines, you may see a lot of side effects which are emerging. So we shouldn't just look at medicines, but medicines do play a very important role in controlling these symptoms. But in addition to medicines, we also need to look at other environmental and psychological and social factors which may be in operation. I'll probably stop there with that. I'm quite happy to take any questions.
Sounds good, doctor, actually. We have sufficient time for Q&A. That was a great presentation. Thank you. So I hope all of you got what doctor was saying. But anyway, let's go over the questions before I do a summary. Who wants to go first? Let me put it on gallery mode. Who has a specific question for doctor? Raise your hand, then you can unmute. Saraswati madam, unmute பண்ணிட்டு கேளுங்க. I'm going to put you on spotlight.
எனக்கு என்னன்னா அவர் நைட் தூங்கும்போது ரோட்ல படுத்துன்னு தூங்குற மாதிரி எனக்கு ஃபீலிங்கா இருக்கு அப்படின்னு சொல்லிட்டு நான் எப்படி வீட்டுக்குள்ள வந்தேன்னு கேக்குறாரு. டெய்லி என்ன அப்படி கேக்குறாரு. அதுக்கு என்ன செய்யறதுன்னு தெரியல. He feel bad.
Correct. Of course. இதனால அவர் ரொம்ப டிஸ்ட்ரெஸ் ஆறாருங்களா?
ஆமா, ரொம்ப அப்படி ஆயிடுறாரு. இப்ப இந்த மீட்டிங் கூட அவர் வரத்துக்கு சங்கடப்படுறாரு. நான் இப்படி ஆயிட்டேனே, ரொம்ப இன்ஃபீரியாரிட்டி காம்ப்ளெக்ஸ் ரொம்ப இருக்கு.
புரியுது. இது வந்து ரொம்ப காமனா நம்ம பாக்குற ப்ராப்ளம் தான் மேடம். இத பத்தி இது பண்ணாதீங்க. இதுக்கு ஏதாவது ட்ரீட்மெண்ட் கொடுத்துட்டு இருக்கீங்களா அப்போ?
ஆமா, அவர் ஒரு நாளைக்கு லெவிபில் 250 mg ஒன்னு எடுத்துக்கிறார். அப்புறம் 7 சிண்டோபா எடுத்துக்கிறாரு ஒரு நாளைக்கு. அதுக்கப்புறம் வந்து பிபி டேப்லெட் எடுத்துக்கிறார்.
மேபி நீங்க நெக்ஸ்ட் டைம் டாக்டர் பார்க்க போகும்போது இந்த விஷயத்தை சொல்லுங்க, இந்த மாதிரி நடக்குதுன்னு சொல்லுங்க.
இப்போ என்னன்னா எனக்கு என்ன டிராபேக்னா அவருக்கு நடையே இல்ல. அதனால இப்ப நான் ஃபர்ஸ்ட் ஃப்ளோர்ல இருக்கேன். எனக்கு அவரை கூட்டின்னு போகிறதுக்கே முடியாதா இருக்கு இப்போ. டாக்டர் கிட்ட
பட் நிறைய டாக்டர்ஸ் வந்து இப்போ வீடியோ கால் பாக்குறாங்க இப்போ. சோ மேபி நீங்க வந்து யூ கேன் ட்ரை தட் அண்ட் யூ திங்க் அபவுட் இட். நீங்க யூ மே இந்த மெடிசின்ஸ் ரிவ்யூ பண்ண வேண்டியிருக்கும். இந்த மாதிரி இருக்குனாக்க அவரோட மெடிசின்ஸ் ரிவ்யூ பண்ண வேண்டியிருக்கும்.
உங்க நம்பர் நீங்க சுதா மேம் கிட்ட குடுக்கறேல, நான் உங்களை வீடியோ கால் போட்டு பேசிக்கிறேன்.
ஷூர் மேடம்.
தேங்க் யூ.
நீங்க ஆன்லைன் கன்சல்டேஷன்
என்னோட அப்பாயின்ட்மென்ட்ஸ் நம்பர் வேற இருக்கு. பண்றேன். ஐ அம் டூயிங் ஆன்லைன்.
சுதா மேம் நீங்க வாங்கிட்டு எனக்கு தாங்கோ.
தரேன்.
I will give you appointments number taniya irukku. I will give you that number.
Now just contact Dr. Sridhar ma to get the appointment number. Yeah. Solunga sir.
I was taking one Parkinson the last 4 years. Now recently doctor has raised to 3. How to prevent falling into a psychosis problems if I take 3?
How do you know you'll get it, sir? Okay, doctor, what is the...
Sure. I mean, நீங்க in fact madam சொன்ன மாதிரி and sir சொல்ற மாதிரி நீங்க Parkinson's disease மாத்திரை எடுத்துட்டா it doesn't mean that you will invariably develop psychotic symptoms. Again, I'm sorry if I convey that kind of a message. It's not that everyone who takes anti-Parkinson's or dopaminergic drugs will develop psychotics. It doesn't happen like that. Only kind of a proportion of people who take these medicines may develop psychotic symptoms. So don't worry if you're on medicines and your dose is being increased. Don't worry that you will definitely develop psychotic symptoms. There is a risk. There is definitely a risk of developing psychotic symptoms when the dose of your Parkinson's medicines are being increased. That's something which everybody knows. I think your neurologist will be very aware of that. Your doctor will be very aware of that when they are doing it. But if it happens, then obviously we need to kind of then start going back and reduce the dose or put in alternative strategies to manage Parkinson's disease. So that's something which there are standard protocols now available to help with this. So your doctor should be very aware of that. From your side of view, if you develop any symptoms, so maybe you may start experiencing sleep disturbance, you may start experiencing some anxiety symptoms, or if you experience anything like you're seeing things a bit different or something very unusual, you're becoming very scared about certain things. If you have any of those experiences, get back to your doctor as soon as possible. Don't delay it. And that's a crucial part, because sometimes when you ask someone who has had psychotic symptoms, when you ask them, they say they have had it for a while and they haven't actually thought that this was something which could be treated or which could get better. So you don't have to struggle with it. If you have any of those experiences, just get back to your doctor as early as possible, and they can try and address it at the earliest. I think that's the best strategy. But at the same time, while we need to be aware of it, we don't have to be worried about it. It's like COVID. We know COVID is around us. The coronavirus is around us. We have to be aware of it, but we can't, shut down and become very scared of it. That's not the way to live our life. We need to be careful. We need to be, approach it with common sense, but not be afraid and become very scared about things. So நிறைய நீங்க வந்து பாரதியாரோட you have to be influenced by that. You need to have a fearless approach to things, but be very, sensible about it. Don't take, too much of a risk at the same time.
Thank you, sir. Thank you so much.
That's what.
Thank you so much.
Good advice.
Thank you, sir. So, PDல வர எல்லா symptoms எல்லாத்துக்கும் வராது, sir. We can't anticipate everything that's okay. Before we move on, we have one question from Dr. Jnana Pandithan. He's actually thanking doctor for the presentation and saying, are antipsychotic medications like Q-tip useful for controlling psychosis? You want to take that, doctor? I'll come to you, Murli sir, and Raman sir.
Sure. Yeah, definitely. These drugs can be useful. In fact, quetiapine is a drug which is often used when we are dealing with psychotic symptoms in Parkinson's disease. But it doesn't work all the time. As I said before, it's like the step one, the first layer of your management. In fact, the first layer of management is reducing if there is, we kind of look at if there are any new medicines started for Parkinson's disease, or if the dose was increased recently. The first step is actually to go back to the previous dose or reduce the drug, remove the drug, or put in an alternative. So that will be the first step. The second step will be looking at their environment, looking at, engaging them and things like that. The third step will be using a drug like quetiapine. Quetiapine can be useful, but not at very high doses. The problem with quetiapine in higher doses is that it can cause certain heart. We need to be aware of certain, arrhythmias or irregular heart rhythms, which we need to be careful about potentially. And also about falling blood pressure. As we increase the dose, it can cause what we call as orthostatic hypotension. And that's something which we need to be careful about when we're using a higher dose of quetiapine. So particularly when we are having someone with who is a little bit older, and also in Parkinson's disease, we can have a lot of, problems with their blood pressure, control. And that happens naturally because of the disease itself. And there are certain types of Parkinson's or Parkinsonian syndromes where there can be, poor control of blood pressure. So that becomes an issue. So using quetiapine under these circumstances, it has to be done very carefully. So quetiapine is one drug which we can use, and there are other drugs like clozapine, which are also very useful in dealing with very severe psychotic symptoms. And we also tend to use sometimes, drugs like rivastigmine. Rivastigmine is a medicine which is used when people have cognitive impairment, when they have dementia. But I also find it quite useful when you have someone with a lot of psychotic symptoms, a little bit of cognitive impairment, and all that, which often come together. So we need to remember that psychotic symptoms don't happen in isolation. You'll have Parkinson's disease, which is in the background. So you may have some you may have some depression, and you also will have psychotic symptoms along with it. So you may have a complex mixture of these things. And then in those circumstances, I tend to use a bit of rivastigmine, which can be potentially useful to resolve any symptoms. So I hope I have answered your question.
Sorry, I was muted. That was very lucid, doctor. Dr. Jnana Pandithan, do you have any follow-up question to ask? Can you unmute yourself? Oru nimisham Rajan, sir, I'll come to you. No, I think Mr. Jnana Pandithan, I can't see him. Okay, I'm going to move to Mr. Mute la irukeenga, sir. You're still in mute. Madam.
Good afternoon, doctor.
Solunga.
Good afternoon.
2007 இருந்து பார்க்கின்சன். நான் வந்து எல்லா டாக்டர்ஸ் இது வரைக்கும் பாஸ்டன் கொடுத்துருந்தாங்க. ரீசெண்டாக பாஸ்டன் நிறுத்திட்டேன். பாஸ்டன் சாப்பிடக்கூடாதா?
ரீசெண்டா பாசிட்டைன் நிறுத்திட்டேன். பாசிட்டைன் சாப்பிடக்கூடாதா அப்படின்னு கேக்குறாரு. எதனால பாசிட்டைன் நிறுத்தினாங்க சார் உங்களுக்கு?
இட்ஸ் பேண்ட் இன் அப்ராட் அப்படின்னு சொல்லிட்டு
இட்ஸ் பேண்ட் இன் அப்ராட் அப்படின்னு சொல்லிட்டு நிறுத்திட்டாங்க. அதை எடுத்துக்க கூடாதா அப்படின்னு கேக்குறாரு.
Okay, அவங்க எதுக்காக உங்களுக்கு நிறுத்தினாங்கன்னு எனக்கு தெரியல. See, again, I would probably not entertain individual treatment questions like this, because I don't think I can't give you a full answer without doing a full assessment and getting to know everything, every detail. But I kind of get this question about Pacitane being banned. Pacitane is useful, has its use. Any drug, if you look at it, it has its use, and we can't just overgeneralize its use. So I don't think Pacitane is banned in India, and it's still being used for many conditions, particularly in Parkinson's disease. But what we need to remember is Pacitane can potentially worsen the cognition of someone with Parkinson's disease. So if you have someone கொஞ்சம் confused இருக்காங்க, they're a little bit, they have a bit of memory problem, or they have a bit of problem with their attention and orientation, or they may have some, even when they start developing psychotic symptoms, I generally advise against using Pacitane in those circumstances. Even though Pacitane can be really useful in controlling some of the Parkinsonian symptoms like tremors, Pacitane can be quite useful. But unfortunately, it can have a negative effect on their cognitive functions, and also for their psychosis. They may start having a lot more confusion, a lot more agitation because of Pacitane. So in those circumstances, I would advise against using Pacitane. I'm sure your doctor has done the right thing, has made the right decision to change drugs. Again, no doctor makes a decision either to prescribe a drug or stop a drug without a lot of thought going into it. So when we think about giving a new drug or adjusting the dose of your drug or stopping a drug, there's a lot of process goes on. There's a protocol which many of us follow, why it's being done. Okay.
Thank you.
Thank you, Dr. Raman sir. I will come to you. Don't keep unmuting yourself. Wait. I will come to you, sir.
Can I ask now?
Yeah. Ready. You're in spotlight. Ask.
Okay, good afternoon, doctor.
Good afternoon, sir.
Just a couple of days ago, I saw an interview on the television in which a psychiatrist was being interviewed. He was saying that one of the most harmless drugs which is maligned is CBD oil. And does CBD oil have a role in psychotic treatment of psychotic? CBD oil.
Cannabis. Okay. Yeah, cannabinoids. Okay. Sure.
Yes.
Okay.
Whether it has any role too?
Sure. I don't know, sir. I don't know. Because I haven't actually looked at any recent evidence for using cannabinoid drugs in Parkinson's disease or psychosis in Parkinson's disease. It may have a role in muscle relaxation. It may have a role in general sense of well-being and reducing anxiety, improving appetite, and things like that. There are lots of studies used in that regard. But I honestly don't know the up-to-date information on that. And maybe that's something which I can find out, and I can let you know if you give me a little bit of time.
Okay, sounds good.
Sure.
Okay, thank you, Rajan.
Thank you.
One last question from Mr. Devashish, and then we will let you go, doctor. Sorry about that.
Thank you.
Devashish sir, please ask your question. Unmute yourself, sir.
Hello, Dr. Sridhar. I'm very grateful to you for your speech, for your talk on this. I like to say that I've got some problems of hallucinations.
You're most welcome, sir.
I've got some problems in hallucinations and excessive salivation. And I can't sleep the whole day.
Nights? Are you able to sleep at the nights, Mr.?
Not so well. Sleep sometimes, not always, but short period. Hardly about 3-4 hours.
Right.
So, what?
Sure, sir. I would recommend that you meet your doctor.
Yeah.
And I would recommend that they can advise you. So generally, sleep disturbance is an issue, and I'll give you some simple tips. It may or may not be applicable in your individual circumstances, but you can suggest. I mean, sleep disturbance in Parkinson's disease is a separate topic on its own. I know I haven't touched a lot on that, but to give you a very brief overview, sleep is very important as for all of us, for a good brain function, for us to be very, and we are understanding more about the importance of sleep in the recent past when we talk about how sleep actually reduces the risk of developing problems later on in life. So yeah, sleep is extremely important. Now, common problems with sleep is, one thing is when you have someone with Parkinson's disease and when they're not being active and they're not being engaged, we tend to nap. Even if they nap for 10 times during the day, that accumulates to 2 to 3 hours of sleep, then you will see that the nighttime sleep becomes very affected. So very, very less. So I generally know it's extremely difficult, and I don't think you can change it overnight. So if you have maybe say 3 or 4 naps through the day, and each say lasting for about 20 minutes or 30 minutes or something like that, you try and reduce it by 5 minutes each time. So you can have your family member, you can set an alarm or somebody to come and wake you up and things like that. So you kind of try to reduce the amount of sleep that you're having through the day. So that's one thing which I generally tend to advise. And over a period of time, say it may take a month, it may take 2 months for it to change and then give you a benefit, but it'll eventually settle down. And it is time consuming, can be frustrating to begin with, but it's definitely worth trying. So reduce the amount of sleep during the daytime. The second important thing is reducing the amount of stimulating drinks, some coffee and tea, and amount of coffee and tea being taken during the daytime. I would kind of strongly advise against reducing I strongly advise reducing the kind of amount of caffeine take through the day, afternoon, 2 or 3 o'clock in the afternoon. Avoid any caffeinated drinks so that you're on an electronic device or handheld devices, mobile phones, or having tablet computers and things like that, or even watching TV for a long period of time later in the evening. So about 2 hours before your actual sleep time, I would say completely cut off from these electronic things, because when you have constant stimulus going into your eyes through the day, and particularly as later in the day, it can delay your sleep cycle, because there is a natural substance in our brain called melatonin, which is secreted, and that gets secreted only when there is reduced amount of light going into our eyes. So there is a direct link between our vision, light pathway, and the melatonin pathway. So when you kind of increase the amount of light input into the eyes, it kind of decreases your melatonin secretion for facilitating sleep. So avoid, and having a mobile phone, having a tablet computer, having a TV in front of you till say 11 o'clock, 12 o'clock at night can actually, particularly now with the IPL season, this is which I've seen quite a lot recently. People are watching till 11:30 in the night, and then they go to bed and they can't sleep for a long period of doing that later in the evenings. So if you're taking medicines in the night dose, maybe you need to have a discussion with your doctor about whether some of these medicines can be shifted to other times. Particularly, and again, I don't want to name because that will raise a lot of anxiety and a lot of questions. Go and have a discussion with your doctor about what medicines are being used and whether those medicines can affect your sleep and whether they can be changed to a different time. Exercise, physical activity through the day, and also a healthy diet, a reasonable diet. If you have another important reason for sleep disturbance is when they have associated diabetes or other problems, they have to get up a few times in the evening during the night time to use the bathroom. See if they're all being controlled reasonably well. And particularly in men, if they have a prostate problem, they may have to get up quite frequently to use the toilet. That can be very disturbing for their sleep. So we may have to address a lot of other associated issues. And if you've covered all these things and everything else has been addressed and your sleep problems still,
Doctor, fair enough. Thank you so much. Doctor is really running short of time, but Mr. Srikanth had his hand up. Sorry, you have to excuse us, doctor, and take question from Mr. Srikanth. Unmute one. That in a question.
Doctor, this will be a very small question. The physical symptoms of a Parkinson's patient deteriorate inexorably but very gradually over time. What about psychotic symptoms?
What about?
Psychotic symptoms.
Right.
Okay.
Psychotic symptoms.
Mm.
Yeah. See, psychotic symptoms are treatable. I mean, that's something, that's a message that I would like to give you, that we can control it to a large extent. We can, in fact, cure it. I've seen people getting completely, better with the psychotic symptoms. But again, we need to know the circumstances under which the psychotic symptoms are happening. You may have psychotic symptoms, as I said. It can be an isolated symptom along with Parkinson's disease, or it can be associated when someone develops cognitive impairment and dementia in Parkinson's disease, and then you may have to treat it in that sense. So in a majority of patients for psychotic symptoms, we can definitely reduce the symptom severity. Definitely in some of them, we can completely get rid of them, which is very good. And it doesn't mean that when someone develops psychosis, they need to suffer for the rest of their life. So we can definitely control it to a large extent in the middle. Okay.
Okay,
Thank you.
that's great.